I think 3 cases, depending on how long they take. So this first one is a guy I just happened to see in clinic last week for follow-up. So remembered I was doing this symposium and our case discussion. Thought it'd be a good one to talk about. So this is, I think, a 28-year-old kid, construction worker. He's a kid you'd like your daughter to be dating, just a straight shooter, doesn't do drugs, articulate, well-dressed. He just was involved in a car accident, I think it was. But anyway, he had this injury about 2 years ago. So I mentioned yesterday, this is the kind of case that the residents will present this x-ray and start talking about their plan. I'm like, wait a minute, let's understand their fracture a little bit better. So here's some tip x-ray. So I mentioned yesterday the importance of the lateral and the AP, and I think, these images look a little worse. I actually don't have the traction internal rotation view that I told you we always get to show you, but this is obviously a varus angulated displaced fracture. You get a sense of some combination. So are you all happy with these x-rays to make up?
Yeah, I think if you go back to the AP pelvis, this kid's got quite an offset too, huh?
Yeah.
Yeah, I think that's important. He's really shortened and externally rotated on the left side.
Mm-hmm.
You can see how much displacement there is in the lateral image there. I mean, he's like, he's the 2 pieces are orthogonal to one another almost.
Right.
Joe, what would you do with that in the interim period? So go down to the emergency room, young kid, healthy, it's 11 o'clock at night.
Yeah, I think getting a nice traction x-ray wouldn't hurt if the patient's comfortable or can be made comfortable while the operating room team's coming in. But I would fix it in the middle of the night.
Is there a role for aspirating the capsule or putting in a traction, doing it in the morning? Or do you want to do it at night? You get your team in at night.
Or do you even have a team? Let's get to that point.
Don't do it. Don't do it.
I think if you have a team, you bring them in and do it in the middle of the night. Like 28-year-old, I feel like that's the thing you have to do. And I don't think there's any evidence that aspiration makes any difference in the management of these patients.
No, absolutely not.
And I think, if you've got a hard case to do, you want to be awake, alert, caffeined up, your morning cup of coffee, whatever it is. You don't want to be worrying about other cases you might also have to do in the middle of the night that are emergencies. And having at least some sort of orthopedic team with you that is becoming more of a challenge these days. But yeah.
Yeah. Yeah, those.
Right. And you get in there and you open it up because you can't get it closed, and then you open it and it's like there's no cortical read there whatsoever, and you're putting it together and taking it apart 4 times. But now it's 4:30 in the morning with the urology nurse.
I would though say I think the most important thing is degree of displacement and then reduction for sure. But all things being equal, I think time makes a difference too. I mean, I don't think you can leave it for 72 hours.
No.
So I guess at what point?
No, definitely not. But first case, you've got a trauma room next morning. It's, you're going to get the patient in the room at 7:30 in the morning.
I think those are all things to take into consideration.
Yep.
And you have to play it by ear, what you're ready to do and what your
team's ready
institution's ready to do. I have a team at midnight. I can drink coffee and get ready, and I think you got to give this kid the best chance to have a good hip.
Yep.
Yeah, but I guess my question, and sorry, you didn't ask for my opinion, but I'm giving it anyway.
We seldom do.
I think everybody probably does I treat my patients just like I want to be treated. And I don't look at this and say, okay, timing's an issue. If I felt like there was something to say, this damage wasn't done on the accident, it's occurring still, and I need to get this reduced, I'd go in the middle of the night. I don't have any problem doing that. But I also don't have any problem bumping the rest of my cases for the next day, putting it on the first case, and have my awesome scrub that I always have that has everything there for me. And so I don't have any problem doing this. Now, if I felt like I was causing damage, and I think you may feel like that by waiting, and that's why you do it in the middle of the night, and that's why you maybe want me to come in the middle of the night and do yours. But my point is I don't feel like there's being damage caused by sitting on it.
I mean, I guess the issue is what is the blood supply to the head right now? So is there any retinacular blood supply? And if the leg's moving all over the place, what is that movement actually doing to the blood supply? And I don't know the answer to that question, but I think in a 28-year-old, I'm going to try and get this done as quickly as I can if I have the resources available to make that happen.
Yeah, that's a good way to put it. You got the resources.
So here's a CT scan. I mentioned yesterday we don't often get these in these injuries, at least traditionally, but this is more of a trauma patient, a car accident, and had the trauma CT scan done, in seconds before we were even consulted. But this just to show you, and I think Sam or someone picked up on, this is almost at 90. The average amount of directional rotation, I think I said, was about 44 degrees. This is, closer to 90 degrees. So, and you can see the comminution inferiorly, and you get more information about.
So this actually makes me feel a little bit better about the blood supply than if it was the opposite, internal rotation, because most of those pedicles are coming from the back side. But again,
But the data has shown in old people that if you have more than 20 degrees of apex anterior, those patients benefit more from a replacement than a fixation.
I'm a little slow. I don't know what you mean by that, Joe. I'm okay with that.
That just predicts loss of fixation, especially in impacted ones.
Yeah.
You think they're impacted.
So we got to this got the OR pretty quickly, and this is a closed reduction. We worked really hard at getting it as good as we could, and I was use the DHS for the reasons we talked about yesterday. Cantilevered screws are not going to support that kind of a fracture. And I don't have the AP pelvis to compare, but as Joe, I think it was pointed out, this kid has a very high offset neck to begin with. But that was the initial reduction, and that inferior comminution. I mean, we've not been big uses of medial, inframedial neck, femoral neck, plates at our center. But anyway, and that's usually for that that apical piece that you get, and here when it's comminuted, I'm not sure that
there's nothing of buttress there. You've got a
Right.
comminuted, comminuted
Exactly.
for your neck fragment. Did you do this on a traction table or free leg, or how did you set this up?
we usually use a haunted table and have the foot in the boot, the Jackson flat top table with a foot in the boot, and we can manipulate it pretty well that way.
So, Andy, I love what you're doing, the contract. Have you ever, so you said closed, have you ever closed, reduce it, and then open it and look at what you've got, and you just don't think there's a value of opening it, or?
That's an interesting thought, because I reviewed a paper where they did that.
That was my paper you rejected, by the way, but anyway.
They did a reduction and fixation first, and then did the open reduction and put a plate on, which sort of seemed backwards to the way I've always thought about it. But I've had trouble with open reduction because there's talk about impaction. The piece is I've never sure that I have it well open anyway, because they just don't fit. There's like a comminution and those things. But so we work really hard at a closed, and sometimes if we just can't get it, I think as Sam said, we'll open it. But I've not done that. Do you do that? Where you?
No, I try to get it the best I can, and I open it, and I'm always surprised that I'm actually dicking with it a little bit. Now, I talked a little bit to Sam. The biggest predictor of instability, not necessarily failure, but probably failure too, is that triangular piece along your calcar. Mm-hmm. That really is like 9 times loss of your stability. But so sometimes, and I asked Sam just on the side, I said, do you ever just kind of do your osteotomy ahead of time and put it in a little valgus? And I do. I compress the more lateral side of it because I put that Youngbluth clamp in anteriorly and over reduce it into a little bit of valgus because I know I don't have any calcar I haven't gone to putting a plate, but I don't know if that would maybe help as well. But I don't know. That's what I would try to do. But
Well, that high offset morphology, I think, is scary. And I mentioned yesterday for intertrocks that I was taught early in my career to use a valgus,
right.
Screw and side plate and tip them up. And Tom Brecka still talks about that, when he fixes hip fractures. But yeah, that's an interesting concept because
I mean, that's been looked at. That people have done that. There's at least one paper that I know of that's actually tested that and didn't really change their rates of union and AVN. But it's an interesting concept. Certainly, mechanically, it makes a lot of sense. It's what we do when these don't. I feel like I always have a conflict of interest because my favorite operation in the world is a Pals osteotomy. So I'm always thinking like, shoot, darn it, I get to do my favorite operation. But, it's really a very elegant mechanical solution to these problems.
So, Tim, you had your hand up?
Yeah, what was the time from admission to the emergency room until you fixed it?
What's the time for admission?
Yeah.
What was the timeline?
This guy, I think he came in, I think that was ideal. Like he came in the morning, as I remember, and, was worked up for a little bit and got him in our trauma room quickly, 4 or 6 hours or something like that. So this is an x-ray that's roughly 6-8 weeks post-operatively. And if you look closely, they're not quite the same angle, but, it appears that there's been a little bit of collapse when you look at that derotation screw especially. But otherwise, the reduction seems to be maintained on both views. This is an x-ray now, I think about 7 months post-injury. What do y'all think of this?
I mean, that inferior piece looks like it's, it's bridging. It looks like it's starting to heal. I mean, I can't tell. You certainly don't know at this point. What did you say? You're
6-7 months, yeah.
6-7 months. That's pretty good. Yeah, that's pretty good. That's
So
probably healing.
And
Yeah.
did you
Or healed.
press the screw initially? Like, did you try to
The
press
derotation
the
screw?
fracture site? Yeah, the lag screw.
It looks like it.
It's shortened for sure.
Yeah,
I mean,
it's-
it's
you-
backed out.
it's
I mean,
backed
I
out.
think there's been some
Yeah.
gradual collapse there.
The
for sure, but-
derotation screw is backed out, almost twice as far, and you can now see
On the initial one, did you try to put?
I think often I do, but I don't think I did in this one because it was so common.
So commented, yeah.
But the machine worked.
Yeah. So, this is working as intended. He still seems to have a reasonable neck length despite the obvious collapse. He's a construction worker. His those iron worker guys who, kind of the highest echelon, construction worker. These very strenuous job, and he was still having some pain. But there's a question about whether he could really go back to full activity. So he had the CT scan done.
Uh-oh.
Change anything? I thought about showing the whole movie, but there's pretty clearly when you go through the various sections that there's a non-union.
Yep. Yeah, it looks like it's...
Do you think that screw had threads on both sides of it?
Both
Not. I'm talking.
You're talking about the
Sides of the
anti-rotation screw. Yeah.
Possible.
No, but it backed out.
That's true.
Yeah.
Yeah, probably just shortened through, and now it's kind of abutting the fracture. Yeah, that's interesting. I mean, it's clearly
So now you can
not
do
healed.
His favorite operation.
Well, what about the state of the head on the axial?
Yeah.
Yeah, it looks like.
I mean, is this a non-union, or is he developing, some AVN, or a little bit of both?
Yeah, I mean, there's some comminution up in that superlateral
Right.
corner where that, I think is what you guys are looking at.
Yep.
Andy, what discussion did you have with him at this point?
Well, he's so young, we had the talk about a hip replacement and all that, but, we opted for the
Tom's
osteotomy.
favorite osteotomy.
So did you assess the vascularity of the head, like do a bone scan or something, or?
No, but that's, yeah.
Would that have changed your treatment?
Maybe if it was dead, I might have started to talk about total hip.
It's a hard discussion, right? Because as we talked about yesterday, you may not know whether that AVN is gonna collapse for a year or two, right? But you've got to act on the non-union
Yeah.
before then,
And it's already fairly
Right.
lateral and peripheral, so you had to do that osteotomy, maybe
right?
out of the.
You're gonna bring that out of weight bearing to some degree. Okay.
So did you do the routine? This looks like a 120-degree blade plate, 30-degree wedge, put it in perpendicular. Mm-hmm. Yeah.
So here is a couple months after the osteotomy and progressing towards weight bearing. And this was the x-ray I took in clinic last week.
How far out?
He's a year is out or so from his osteotomy, about 9 months out from his osteotomy. He's got clicking in his hip and pain that's getting a little worse. And
How short is he?
so I should have put this in. I actually got a long leg standing view to kind of, because then we're talking about, that segment ahead looks dead. He did have a CT scan. I guess I didn't put it in, but that same upper corner just looks like it's developing osteonecrosis, and he's not back at work. And you can appreciate the apparent leg length discrepancy here too. And on the standing view, and it's quite obvious the difference in offset that he has. And this is just one of those fundamental problems with neck fractures, like someone mentioned yesterday. Like you can't,
you can't have
paradox.
it both ways.
They can't
it's
heal.
a paradox, right? I mean, they have to shorten to heal, especially these comminuted ones, and that obviously portends a worse clinical outcome.
I mean, I think the one important thing too is when you're doing that osteotomy, you have to make sure you're not displacing the shaft, because that can really affect your ability to do the total hip.
Yeah, I mean, it's just amazing. All the things I was most worried about, that inframedial comminution, that turned out really not to.
I know that ended up healing just fine, and it was the cranial aspect.
I think if you go back to one or two slides, no, forward,
Well, the other way.
forward, right, one more. So I think that proximal of the 4 screws is a little long, because Andy did a good job of pulling that shaft back to the plate and impacting the osteotomy site. That's nice. That's why that screw is probably too long. Yeah, it's not too long. It did its job.
The workhorse screw.
Yeah.
Yeah, so unfortunately, this now 29-year-old, 30-year-old guy is going to be looking at a total hip, but that should get him back to work, hopefully.
Total hip, go back to work. Total hip, go back to work.
Yep.
All right.
Cool.
Another
Want
one?
to do it?
Got another?
Yeah, I can.
Yeah. All right.
That was the most complex.
Mail you, okay?
Oh yeah.
Yeah.
So we probably ought to actually, if we're going to just do one more, I'll probably go to the next one, but I'll just do this really quick. So this is sort of the opposite. It's a person who is not dependable, housing insecurity, substance abuse use, has, less, severe looking fracture. I don't know the mechanism of injury is actually understood, but this, we'll just go this pretty quickly. So it's the same kind of question, like, can you make decisions on just these x-rays? So, we'll get on to the next one, but we did get a CT scan, so it's a more vertical fracture in the coronal view. It looks fairly transverse on the lateral view. There's that same rotational deformity that is quite commonly seen. So this one we did a fixation. So here's the intraoperative imaging, the closed reduction. There's the same fixation, but this is one. Reduction isn't actually quite as good as that last one, I think, and you see that the calcar doesn't line up quite as well as I thought we had it here. Here I thought it was mostly just gapped a little bit, and but
In the valgus.
yeah, tipped up in a little bit of valgus, but here it's kind of slid down a little bit. So what do y'all think? Is this going to go on and heal or not?
Do you have a lateral?
There should
like
be a
on
lateral there.
He's homeless, so yes, he's going to go.
So he's going to heal. He's going to be fine. Yeah.
And he went back to work.
Yeah, so so here we are at 2 months post-op. It's hard to know if that's a little bit worse or not, if it's just a difference in radiographic projection. Still looks decent on the lateral. But this one, short answer is this one went on and healed. The person was lost to follow-up when I was going through this chart, found, for some reason they were in, and got another CT scan done for some other reason, and
Yeah,
it
totally.
seemed like it was healed.
Yeah.
With homeless, always heal.
Yeah, but this is one that we can, how much more time?
Yeah, go ahead.
Yeah,
We
so
got enough.
we actually got a little time. So 65-year-old female, step ladder, fall from step ladder at home. She's an attorney. She's diabetic, on insulin, maintains good glycemic control. She's active. She walks several miles a day, several miles at a time, several days a week. And this is her X-ray. And this is perhaps a little more subtle just looking at it from any distance, but there's a X-ray. But I think it's more obvious on the lateral that there's some tilt, and she's got a femoral neck fracture. Good enough imaging there to make a decision.
I can't really tell how much sagittal plane deformity there's.
Yeah.
Okay,
That's why I do a
got the
CT
CT.
scan.
Yeah, thanks.
So it's impacted a little bit, but there's definitely that axial plane deformity again.
Yeah.
It's a 65-year-old diabetic and it's very active.
Yeah, I mean,
Reasonably active.
there is, somewhere between 20 and 30 degrees of this kind of axial malalignment is what people consider kind of the threshold for, doing an arthroplasty on these. And I don't know, it's highly variable. There's a multi-center clinical trial that's getting ready to roll out now that's going to look at this and hopefully answer this question for us about whether they ought to get arthroplasties or not. So I think the bottom line is we don't really know. If it looks like, on that far right image there, that looks pretty far off. The ice cream scoop's kind of off the cone there, and it's going to be hard to imagine you're going to get 3, good screws in that. To hold it in place. Certainly when you don't have all of that apex anterior angulation, I think it's a lot easier. It's a low morbidity operation. I usually think it's worth a try. I may be proven wrong by this trial, but my own experience is a lot of those heal and they do okay.
Well, I think
but
the key is you talk to the patient. This is a 65-year-old attorney. Say, listen, I can try to save your equipment.
Yeah.
Maybe you get a little bit better reduction and then fix it. And if that doesn't work out, it doesn't heal or goes on to avascular necrosis, we can always do a replacement.
And you can tell them about the deformity, but it's like a skiffy.
Yeah.
And you could put your screws from A to P more.
Yeah, you could. I think there's sufficient uncertainty about this if you really review all of the literature on this topic that I can't advise really strongly one way or the other. So it is a discussion, like you said, Joe.
I think it's for sure a discussion, but I think there's a lot of angulation there.
Yeah,
and,
it's a lot. This one happens to be very angular.
and I would definitely do a total hip in this patient. And I think even with less angulation in a 65-year-old diabetic patient, I think I'd probably be erring towards an arthroplasty. I'm going to do a total hip in this patient.
What do you think about?
I agree to some degree. It's a much simpler and done. But again, I hate to agree with Joe, but I am. But, talking to him and say, yes, the skiffies, they kind of walk with that external thing and rotated. And I think that's impacted enough that you've got good bony contact. So I think that it would probably heal with screws, but I would have no problem doing an arthroplasty on them. And I'd have no problem after it fails to do an arthroplasty. So.
I think the other thing you want to talk about is reoperation risk, and probably it's at least 20% best case in this person you do.
That means 80%. It worked.
Yeah, but with a total hip, it's probably 95% plus.
Why a total and not a hemiarthroplasty?
65-year-old for sure at some point in their life is probably going to need conversion to a total, so might as well do the total to start with.
Yeah, so I showed this X-ray. I was going to go back to the argument about fixation, or not the argument, the discussion about fixation. So you all heard me say that I do a lot of press fit arthroplasties in these cases, and that looks like a beautiful femur to do a press fit implant.
Oh boy,
doesn't it?
Yeah.
So what did I do?
You put screws in it.
Cemented one. And
good man. Good.
It may just be that the resident really wanted to do a cemented one, but my usual protocol is what we talked about yesterday. I use the same system that in these cases that I use for my primary arthroplasties, and it's a broach system. So I'm broaching, and if I'm not happy with the fixation, especially the rotational stability of the broach, when I get up to about 14, 15 millimeters, it's proportional to the patient. Then I just cement. But she got a cemented implant, but is doing well.
Is this a high offset prosthesis?
I think it is. Looking at it, I didn't note that, but you do. This system does have standard and high offset, and it looks like it. But
looks like a high.
It's probably because the malposition of the cup. No, I'm just joking. It's a little bit vertical, at least on this.
All right.
Good. Thanks.
All right, Emil.